Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today's guest is Dr. Maria Sokolina, a dentist who is dedicated to creating a healthier world by promoting sound sleep and healthful breathing. Originally from Russia, Dr. Sokolina earned her DDS degree from the New York University College of Dentistry and is founder and CEO of Harmony Dental Arts in Clifton, New Jersey. She hosts a Facebook and YouTube channel dedicated to sleep and breathing, where through interviews with medical and dental professionals, as well as patients and parents of patients, she aims to create a supportive community for individuals navigating this challenging journey. As an aside, I recently had the privilege of being a guest on her channel, so I'll put a link to that in the show notes for today's episode. Dr. Sokolina is a diplomat and board member of the American Academy of Dental Sleep Medicine and lectures nationally for both the dental and medical communities on sleep, breathing, and wellness. Some of what we discuss on today's show includes the issues that she sees in adults who have had previous orthodontic treatment where airway health was ignored, whether or not premolar extractions impact airway development and long-term sleep health, why so many orthodontists don't address either myofunctional habits or transverse deficiencies in the absence of crossbite and instead focus solely on straightening teeth, how ignoring the impact of airway and myofunctional habits can decrease the long-term stability of orthodontic treatment, how all dentists, both generalists and specialists, can integrate sleep medicine principles into their practices, and much, much more. So without further ado, let's get on to today's episode with Dr. Maria Sokolina. Enjoy the show, everybody. Welcome to the Doc Podcast, Maria.
Thank you very much. I'm really honored to be here.
I'm really excited to have you. You have a really cool story and journey. And as I so often say, I love hearing about it because everybody sees the Dr. Maria you are today and how much you know about this arena of airway and health and wellness and myofunctional therapy and how that all ties into helping your patients. And we're going to talk about a lot of that today. But how did you get here? How did you get to this point where you are now?
I'm going to give you a short version. I got here from fear. I was really scared what my restoration gonna break. And now I give you the longer version of it. I came from Russia, so I had a dental education before I started NYU. And then I had a GP residency, and we were exposed to different areas. And then I got out into this scary world, and I didn't know where are going to be my footsteps. What am I going to do? I really love ortho. I tried to get into ortho residency, but it did not happen. And then I got into private practice. I purchased my practice. And in a private practice, I'm a very aesthetic person. I like to create beauty. I want everything what I touch would have great result, artistic results. But I was so scared what it's going to break. And I took a lot of prosthetic courses. And I thought I'm going to use the strongest materials. And then my crowns or veneers going to stay intact. But guess what? Even if I protect them with a night guard, they didn't. And then I got back to my love for ortho. I know how to do ortho. And I thought I'm going to position teeth in the right position and use the strongest material. And then they're not going to relax or move or they're not going to break. Happened to be not true. And then I heard about sleep. It was many years ago. It was more than 15 years ago. And they were talking about what if patients have extreme forces because they cannot breathe at night. You can stand on your hand. Whatever you're going to put in a patient's mouth, not going to fly. They're going to break it sure enough. Maybe not right away, but over the course of years, they will. And they've done in your office as an emergency, and all my fears would come alive. Yeah. So I have to learn about sleep. But as a serious person, I take everything very seriously and comprehensively. I start learning about sleep in sleep labs. I follow the sleep technician. I look what happened with patients during the sleep. Oh, I had that amazing experience. And I start my traditional dental sleep medicine journey just a long time ago, and I was doing oral appliance therapy. But guess what? I still was the same aesthetic person. I really didn't like when they come with this crowding and such a tiny mouth and open lips and nose being clogged. My oral appliance therapy didn't work well either. Even though I was able to protect the dentistry I did, it still didn't satisfy me. And with the dental sleep medicine, it's a little bit different relationship because you're not the captain of the team like you are in your dental office. You are part of the team with a medical practitioner, and your captain is your sleep doctor, who would look at the sleep test after I complete my oral appliance therapy and said, no, that's not good. That's not good. Your therapy didn't work. And then I start adding different components to that. And we're talking about nasal hygiene. We're talking about myofunctional therapy. And I got back to my love for ortho. Because yes, even though I don't do skeletal expansion myself, with the clear aligners, I can do oral appliance therapy and still get dental expansion. And I firmly believe what function follow the form. So if I'm able, even to, not fully, but even to improve the function, I'm talking about nose breathing, I'm talking about tongue position, I'm talking about lip strength. If I even am able to improve it a little bit for the patient or a lot, it's going to affect my result. And I'm not going to be that embarrassed getting the letters from regular sleep medicine doctors. So that's my story.
It's really neat to see the common thread in so many of the people with whom I speak on this topic is they're thinkers. They weren't okay with just doing it the same way they had maybe been taught to do it or had started doing it for their years in practice. And conversely, a lot of the people who don't want to change are more just, I'm just going to focus on what I do every day, and I'm going to keep restoring these teeth in the general dental arena or doing veneers or rebuilding bridges or trying to increase the VDO or making night guards to patch and, again, treat the symptom. Not too different from the orthodontist just trying to straighten the teeth in the case when the bones are not fitting together, which we'll come to a little bit more in a minute. You took the time to say, well, okay, yes, I could do this and probably make a pretty nice living doing it, right? Those are billable services. A lot of what you're doing in the airway arena is, I hope it's going to improve, but right now it's not as easily billable. It's not as many of the ADA codes apply to it and the CDT codes. So there are more challenges there, but you had the vision to want to do something greater. So when you started trying this, what does that look like? Because I find a lot of people that I coach and help, they're scared to first take that leap. And I had an episode recently with Dr. Jerry Simmons, who's a sleep physician, and Dr. Steve Carstensen, who helped write the 2017 ADA position statement. And we talked a little bit about that balance of you can't take this too lightly. You don't want to just be like dabbling, throwing intraoral appliances at people and thinking it's going to solve everything, because it's so multifactorial and multifaceted when you get into the sleep arena. But also, you don't want people to be intimidated so much by it that they're scared to start trying it. So what would be your advice to docs out there of really any age who are starting to think, well, maybe there is something to this, and maybe I would like for the orthodontist to pull less teeth, or maybe I would like for the restorative dentist to not have to worry that all my veneers are going to break down and these patients are cracking through night guards left and right. How do you help them on that journey to say, number one, have the courage to go for it, but then how do you start that on that journey?
You're absolutely right, Mike. When you talk, I meet a lot of, even a lecture, people talk to me. We took so many courses. I took like 5 courses, 7 courses. But when I get to my practice and start identifying with the patients, I cannot convince them because they have a totally different reason to be in my office. I face the same challenges with my patients. But first of all, you really have to like it. You really have to like to provide comprehensive service. And a lot of things, when you open your eyes, you don't even have to put glasses on there. You just have to open them. You would see the signs of sleep disorder breathing in a patient mouth. And what it means, what your dentistry, what you put a lot of efforts into making a beautiful crown and a perfect margin, it's going to fail. So if you have that feeling, what you don't like failure, which most of the dentists do, we are perfectionists by the way we were raised in dental school, then you start thinking a little bit outside of the box. And if you want to protect yourself, just like I mentioned about my story, so you might like dental sleep medicine from that standpoint. Yes, you cannot take it lightly because it changed your philosophy really deep down. As a dentist, we are perfectionists, medical doctors, they approach it totally different.
What do you mean by that?
That means, but if patient got improvement, not perfect, that's already good. Patient can sleep and wake up not 10 times, but just 2. That's good. Patient oxygen maybe not above 90 in a nadir level, better than it was before. It's also good. They look at the patient health as a journey. For us, we're looking for final result. Okay, we got the veneers, we take a picture, that's the result. For medical doctor, it's a journey. Same as a sleep apnea. It's a lifelong disease. It's a process with a lot of different streets and avenues, different treatment strategy, what patient will face on that journey.
Yeah, that's actually where I was going to go next on that is, so you just said, and I completely agree, that when you are in this end stage disease, obstructive sleep apnea situation, say as an adult, it's a brutal journey at that point. It is, sleep is so fundamental to what we do, and we're learning more and more about it all the time, to all of our physiologic processes. And when you even have a couple nights of bad sleep, like anyone who's a parent knows, right? When you have a couple nights in a row where your little one is up or you have a couple kids, man, you're just dragging during the day. Processing is harder. Even driving, it's harder. Things you do every day on autopilot, just you have to think about. If you exercise, you go to the gym, you feel weaker. You don't have the resilience that you normally do. Now do that every night of your entire life. And so when you talk about that, and we know the negative consequences of obstructive sleep apnea, why do you think, being a general dentist who's gone on this journey and has transformed the way you approach this, what would your advice be to the orthodontists out there, or even the general dental colleagues and pediatric dental colleagues who don't think that we can do things when these kids are young to try to prevent them from ever developing it? And I want to quantify that by saying, because a lot of people in my field feel like, well, if they don't have an AHI of whatever, greater than 0, essentially, for a child, well, they're fine, right? And they think we have to wait until they get to this diagnostic parameter, which we can talk about, and I did with Dr. Simmons, the lack of validity of that in kids anyway. But let's just go with for a second. Let's run with it. That is valid. Well, why do so many of our colleagues fail to acknowledge that we can do some things when they're young to prevent that?
From me, I look at that through totally different eyes. I see the consequences of that. And seeing adults who had 4 bicuspid removed, and it can be controversial topic, I totally get it. But
we'll come back to that because I love that topic. So
they usually have sleep apnea. They usually have temporomandibular joint disorders. Not even a doubt in my mind about that. And I see also myofunctional habits. They are not very well developed, which support why a jaw did not grow. And think about me seeing those patients and helping those patients every day. In my first consultation usually on screen, and I think I'm in that repetitive movie over and over again. I cannot focus all day. I don't feel refreshed. I don't sleep in the same bedroom with my wife. I really want to reunite with my spouse in the bedroom. They all make fun of me on the trip. I cannot, people, it's really affect life in a big way. I'm not talking about teeth. I'm talking about total life dismantling. And I'm in that movie every single day. And after that, to think, why not to address it as a little child?
Thank you. Yeah, I don't know that answer. I try, and I want to stay on that by extraction because it's such a sensitive, hot button issue, which I don't even understand why it's controversial. People ask me all the time, my orthodontic colleagues, they say, do you think extracting four bicuspids causes sleep apnea? And I said, you're asking me the wrong question. It's not the physical act of removing premolars that causes sleep apnea, right? Like it's not like you just take four teeth out and, oh, now you're going to have sleep apnea.
No.
Is why are you taking the four premolars out? Well, the vast majority of the time, it's because the teeth are crowded. So let's just ask a different question. Instead of saying, should I solve this by pulling teeth? Let's ask the question of, why is this patient so crowded? And if it is because this patient, this is the example I love to give. Let's say this patient has like super broad arches, right? Tons of tongue space, beautiful broad palate, can breathe through their nose comfortably, and just has huge teeth, right? It's just this outlying patient. We know that's not the norm, but let's just go with it for a second, just to give the example in the extremes. And they have huge teeth and they're crowded, and you have to remove four teeth. And after you remove the four teeth, there's like almost no additional space to close. Like they were so crowded, right, that you had almost like four extra teeth, right? In that patient, theoretically, you're not going to change the way they breathe, or you're not going to change their airway by removing that physical tooth mass because the structure is normal. Conversely, take a patient who comes in with that same amount of crowding with normal-sized teeth. If they have that amount of crowding, it's almost certain, and there's been numerous studies, I quote them on the show all the time, Mills in the 60s and McNamara in the 80s is a study looking at this, and it's rarely is it ever, Prophet talked about this, is it ever big teeth? So the majority of the time when they have crowding, it has to be the opposite, which is small jaws. And so why are you solving a small jaw problem with a tooth-based solution? That's the question I turn back on people when they say, do I think pulling teeth causes sleep apnea? It's, why are you pulling the teeth? Why don't you help normalize the anatomy and grow the bone? Right? Am I missing something that this isn't that complicated? Like, why is this so hard for people to reconcile?
My view, much more philosophical than just this way. I think it's a paradigm inside of the doctor's head, and that have to be solved from the public standpoint. That's why I write articles, forums, or other magazines, trying to change the idea for public, not in the doctor's head, but for public, what parents would be aware of certain features, and they would search for help themselves, and they would be able to evaluate what help a doctor can offer them. If they're talking about airway, if they're talking about jaw development, or they, of course, everybody wants to solve the problem and live their life afterwards. That's why a year or two of orthodontic treatment become like a pandemic in the United States. Everybody have to have a straight teeth. But if public start thinking a little bit under the different swim lines, then doctors would change. That's my view on that problem. Yes, of course, doctors should think a little bit deeper than the surface. They should look for the root causes. I call it routes to roots. They should find routes to roots for kids and for adults alike.
That's where I feel like that we're missing it is my profession as a board-certified orthodontist. I can say this confidently. We are hyper-focused on being the best tooth straighteners we can be. And while there's a time for that, like that's not a bad thing, right? There's certain complex cases that aren't airway cases. Not everything's an airway case. There's certain things, and you have to be a really good tooth straightener to be a really good orthodontist. That doesn't mean you can't also be aware of why this patient has a malocclusion to begin with. And so many times, and I've said this on the show often, I have colleagues say to me, the cause of this is a mom and a dad, and that's it. There's no influence of environment. And I'm like, how can a highly educated orthodontist who has read the literature from Linda Aronson and Harvold and Moss and all, how can you completely ignore, when I was on your show, which I had a lot of fun doing as well. Thank you for having me on. It's super fun. You do an awesome job with it. I referenced the 1870 Wilhelm Meyer was when the word adenoid facies came about. Like, anybody who says to you, anyone listening to this, if you ever come up against somebody, a colleague who says to you, or even a layperson who says, oh, well, the way we breathe can't affect the shape of the face, ask that person if they believe adenoid facies are a thing, and that if you have obstructive adenoids, it changes the way the face grows. Because I've yet to see a paper that disputes or refutes the fact that if you have obstructive adenoids and become an obligate mouth breather, the way your face grows is different. Again, I've seen many, right? So I tell people all the time, you can't have it both ways. You can't say that it's a mom and a dad and that's it. That's what causes malocclusion. And then also agree, well, there is this thing, adenoid facies, that may be true too. So can't we just agree that when you're an obligate mouth breather, when you're not breathing through your nose, your face grows differently? We now know from the medical literature, your brain grows differently. We know the way you interact with your peers is different because of a lot of these impacts, because how many adults out there who are sleep deprived interact as well with their peers when they're sleep deprived as they do when they're rested? So on that, I love that you're going to educate the parents, and that was super fun, again, on your platform doing some of that. And I need to do a better job with that because I spend so much time trying to educate my colleagues, which is good, and I'm not going to step away from that. I need to also do a little better job getting to the parents, because I have parents contact me all the time through my social media, through my website, and say, I've been to 3 docs and they're all telling me with their 6-year-old child who snores. And I just had one call me last week who I know. And it's like, I can't find an ENT who will do anything with them. And I can't find a dentist or orthodontist who will help this kid. And the parents are suffering. The child is suffering. It's an absolute mess. What do I do? So yeah, the parents, I guess what I'm saying is educating the parents is huge. But if we don't get the providers on board, then these parents now, I'm getting more and more parents who are aware of this because of content like yours, but they don't know what to do. They don't know where to go. And if they're not living near more populated cities or they're in more rural areas, some of these people are driving. Some of these people, Maria, are flying to get basic care from the otolaryngologist and or orthodontist. How do we fix this?
This is a valid point. And of course, you're in Florida, I'm in New York, New Jersey, and it's totally different game to find the provider. And thank you to social media, because now people have access to much more knowledge and a lot of options. And they can communicate, they can actually research the provider they're choosing through social media, through the website, through the reviews. So that's a big plus. Let's start with the positive thing.
Agree.
But if you're in the middle of the country and you have a hard time, yeah, it's a big question. That's true. But I believe we live in a very changing, scientific changing shift right now. And I hope it's going to be more providers who are going to see the true story. Another great thing called telemedicine. I understand it's very difficult to do braces using telemedicine, but clear aligners have that option. I know the observation, yes, true. It's very hard to adjust anything using telemedicine, but you can find a lot of ways of treating people in a way you think it's right. I know there are a lot of limitations with licenses and all of that, but if parent or patient, at least that's what I'm seeing in my practice, if they understand that's the right concept, they're looking for the solution and they find those solutions. Yeah, it can be very difficult. Don't get me wrong. Yes, but I think it's going to change the providers as well. Like what you do with your podcast and what your listeners can do with their social media, if they share the information you post, I think that's going to change. You know that story about the hand washing? He ended up in a mental institution.
Yes.
And now we don't even question what hand washing. It's the right thing to do. It's really hard to imagine the doctor going to touch the patient with the dirty hands. But it used to be, it used to be a really strange thing. And not long ago. It's 150 years ago.
Yeah, it was 1800s,
so, yes.
Ignatius, and going back for a second to what you mentioned about the patients you see who have these problems. Because, and I have a lot of non-orthodontists listen to this show as well, but I think even for them to help my orthodontic colleagues who listen hear this, what are you seeing? What are you seeing in these patients? You alluded to it in the beginning when they come in and these orthodontic results weren't stable. Let's say these are patients who had orthodontic treatment. Talk us through when they come into your practice, what they look like, how they present, and why you're thinking that it might be something to do with a lack of normalizing the anatomy when they were young and only straightening and treating teeth.
My first statement would be a little bit controversial, but anatomy is not everything. I have patients in the practice who have airway. I can run the tray through the airway, and they still have sleep apnea. It's a lot to do with the nose breathing. My first principle would function define the form. So a lot to do with the function. And the form can be acceptable. But it's not the majority of people. Majority of people, they had some sort of lack of development. And yes, crowding, for me, crowding is a sign of disturbed air. Because I look on a crowding from a muscle standpoint, but they have to tense the muscle, and it's not a balance between tongue and a cheek-lip complex, what cause crowding. That's crowding for me. And funny it is, like a lot of colleagues mentioned, I have a lot of families. I'm a general dentist. In addition to being diplomat of dental sleep medicine, I'm a general dentist, and I see a lot of families. And I notice what a certain habits, mouth breathing or open mouth posture goes, yes, I cannot say genetically, but kids absorb it subconsciously. No wonder mom and dad and then the child. So, yes, crowding, and I see, full bicuspid extraction, we just talk about that. I see so many things with those full bicuspid extractions. It relapses orthodontically so easily, and patients have 1, 2, 3, 4 orthodontic treatment. It's so unstable, even in the presence of fixed retainer. Yes, additional things, and I usually lecture about that, but I see a lot of exostosis, and even more now than I saw when I graduated from dental school. People compensate for lack of balance. It might be related to tongue tie. Also, I see a lot of obstructions. Obstruction for me, it's a movement of the tooth and they're losing the enamel. So that I see a lot. Scallop tongue, it's easy, yes. But usually I see open bites. I see open bites posteriorly and anteriorly. And it doesn't have to be the bite you can put the fingers through. And it can be just open bite related to the wrong tongue function when they push the tongue forward to swallow. And with it, I see the compensation. Usually they have those folds.
Yes.
And when they swallow, I see how they tense that. So that would be the classical picture. But then in addition to that, not in the mouth, I see very thick ala of the nose. I cannot find the explanation why it is, but usually it shows to me that this patient is a mouth breather. I don't know why it is getting bigger. And, I usually look at the noses. So I see that a lot.
Yeah, because we're very fortunate in orthodontics that we're not really held accountable for the long-term stability of our results, because we just say, well, the patient didn't wear the retainer. I look, when they left me, their teeth were straight. And sometimes, yes, that is the case, right? Sometimes it's especially patients who start with severe rotations and yes, they have a responsibility to do their part. But the more you put the lips and the tongue and the teeth in balance, the more stable those cases will be. And I know that from personal experience extensively, because when I would go in young on these kids and help them grow earlier and not let those teeth all grow in super crooked, but make the space and normalize the anatomy early, normalize not just the intraoral skeletal anatomy, but also the nasal passageway anatomy and pharyngeal airway anatomy through working with my medical colleagues. When you do that and you restore that or develop that, those kids, the teeth almost always erupted quite nicely. And if they needed a second phase, it was much more routine, much more straightforward. It was easy, and some didn't even need it. And I have tons of cases in my courses I go through that didn't even need a second phase. So now, not any early, you have to know what you're doing early. If you just try to do whatever, it's not going to have the success. And that's unfortunately a lot of our orthodontic research talks about techniques for early treatment that just aren't going to work. And I say all the time, no matter what you do, whether it's restorative dentistry doing a crown or orthodontia doing whatever treatment, phase 1 or Invisalign or clear aligners or whatever, if you don't do it well, of course it's not going to yield a good result. You have to do it well. But when you have those cases, they're stable, they're easy, they're straightforward because you put things in balance. So what you're seeing is these patients who have a complete imbalance of their muscle function, of their teeth. Now, how many of them are bruxing or at least clenching, but clenching, bruxing have these parafunctional habits and have it present with signs and symptoms of TMD as well?
Oh, I would say 90%.
Wow.
It's
Wow.
a huge amount. And I look at the TMD, I'm sorry to interrupt you.
No, go ahead.
TMD is sign of finding a balance. Either it's emotional or physical. People use the teeth to be able to stand on 2 feet. Imagine, it's not that many animals who stand on such a little surface with a huge vertical strain. So we have to find with our muscles and our teeth to find that ability to withstand that load, to be able to stand. Yes, people use it, and bone growth and abstraction happen because they cannot find the balance. But very often, if they support the palate with the tongue, it's much easier to find the balance for the jaw joint and for the physical balance. I work a lot with the physical therapist, and we do guards and we do myofunctional therapy for those patients who going through balance issues. And yes, they do improve.
Yeah, talk a little bit more about that if you would, because that's an area I don't even know as much about as I would like to. When this patient comes in, okay, and you detect this, you see these signs and symptoms, right? Let's just go with its deep bite, abstraction lesions, maybe some TMD issues, crowding. What are you thinking? How are you starting to break this down? Are they coming into you? Do they know anything about airway at this point? Do they not? And how do you take them on that journey? So I guess what I'm asking is, what's your initial diagnostic process? And then how do you start to work with your team, your medical and therapy colleagues to start to put this picture together?
This is a very big question, but I'm going to make it
Yes.
short. So there are 2 ways, my dental patients and my medical patients. My dental patients, it's a long game. They come to me for clinics, whatever, dental services, and I educate them. And then with the evidence, I'm talking about snore lab up. We're trying them to record how they sleep at night. And if they're kids, it's a video recording, little video. How is your child sleeping? Yes, you're right about sleep test is a different story. So video is good because it has to be sound sleep without constant movement. So we try to bring that evidence and offer them sleep consultation with the sleep doctor and work them towards the sleep study. Kids, different from adults, but general terms. So connect them with the medical specialist. And there is a medical part of my practice, people who got referred to me from the sleep doctors.
Okay.
And with them, it's a different path. It immersed treatment because they usually have a sleep apnea. They can have a TMD, but most of them, they have a sleep apnea. And I offer them oral appliance therapy in conjunction with orthodontics or without. In conjunction with myofunctional therapy or without. And I consider oral appliance therapy like a bandage. It's a wound and you need to have a bandage. Then we're talking about a long-term solution. And then I offer them different treatment plans.
Okay.
And yes, they include myofunctional therapy. And you ask me about physical therapy. Yes, I have a great physical therapy team. Not one team. I'm talking about different specialists. And a lot of them I interview on my channel, sleep apnea, breathing, snoring, help. And I see it's a developing area. Not a lot of people are aware about that. But I can tell you, 20% of my practice had some type of spinal surgery. Spinal surgery. In the neck or back. A lot of people have this type of disease, this type of problem. But maybe not a lot of people are aware what conservative way exists as well. And working with a physical therapist on making the balance of your body in a different areas can help you to avoid this very invasive surgery. And not a lot of people know about that. And guards, it's called MMOO, special type of guard, help patients to reprogram the body, what it act on both sides symmetrically, or they can transfer from one side to another because we stand on one foot and then on another. our teeth touch on one side and another. We're very balanced. We're very fine-tuned computer, and we use our teeth to program. And with the guard, we can reprogram. So I work with the physical therapist on the patients who have pain in the neck, in the shoulders, in other part. Also, people who have difficulties breathing because chest is very tense or constricted, I would say. They cannot get from chest breathing to diaphragmal breathing. And the guard help
big.
that way. Guard help as well. So thank you for asking that question. I'm the big fan of PRI Institute, Postural Restoration Institute. They were also on our conference when we met. And I saw the work of physical therapists and manual therapists. And I'm a very conservative person, and it reflects my philosophy. I rather offer conservative therapy than something dramatic like for bicuspid extraction.
Thank you for explaining that so well, because it's something that I'm learning as I'm speaking with you on this, on what the involvement. I did have a physical therapist on the show, and we talked a little bit about some of these things, more as it pertained to the ergonomics of the dentist and the provider, but it applies obviously to our patients as well. How do you structure the billing for this? You don't have to give the amounts that you're charging, but because as we started to say, a lot of people don't go this route because a lot of times when Dr. Claudia Pinter was on my show, she said it's sad how often the treatment follows the reimbursement. And last time I checked, people may not have coverage for physical therapy or these certain types of splints or oral appliances you're doing, which the lab fees, I'm guessing, are probably a decent amount higher. These are more specialized than just a little send it in to the lab. They send you, take a 3D scan, send it in. They send you back a little articulated bite guard and you give it to the patient. So how are you handling that side of it from a financial standpoint where it can still be generating enough revenue for you to have your business be profitable, but also be affordable to the patients who may not have coverage for these services?
This is my philosophy. It's totally different chapter of the practice, and it's not least important than actual treatment. I always put it in my articles. As a dentist, we have that stigma, not only for the physical pain or discomfort that patients go through, but also financial not clarity, work, financial work, because people don't understand how insurance works. They don't understand what would be the arrangements. I think that's a very important part. And for dental sleep medicine, I know a lot of providers stop offering that because they cannot crack the dental sleep medicine insurance patient financial relationship. And for that reason, I had several people on my show, including dental writer. They talk about coverage, exactly how to make reimbursement work. So my heart goes for the patient. And I think it's very important for relationship with medical providers. Yes, I do try to maximize medical insurance coverage. True, you have to be knowledgeable. You have to constantly educate yourself. And no, I don't do medical billing. I do have a medical billing department. I have a team what belongs to my practice, and we work with a medical billing agency who really bill medical insurance. Yes, it's a lot of steps, and you have to do a lot of system to create to make it work. But in the same time, it's a very noble goal in the end to help somebody to have a happier life. That's why we're in the medical field. You know, dollar sign, if your dollar sign is constantly blinking in the head, it's not a great area. Because you first have to learn. You have to learn how and create those systems. And then, yes, they can be financially lucrative. Don't get me wrong. It's a great financial reward for my practice, dental sleep medicine. Very truly. But I do work with medical insurances. And yes, if medical insurance is not covered, it's a patient responsibility. And yes, I have to inform the patient, not me personally, I have a team. And they inform the patient about different financial options, what they can do to have that treatment. And I can say, this is what I learned that from not being American, I'm from a different culture. A lot of things I have to learn. And that's what I learned. If somebody understand how this treatment gonna benefit them, they're gonna find the resources to have it done.
Mm-hmm.
If opposite way, that means they don't find this treatment so important for this stage of their life, and they might come back. But my job is to educate them, make it available, make knowledge available, and then we go from there. True story, guards, that type of guards, they're not covered by medical insurance, at least for now, or at least I didn't find a way to make this treatment work. Some insurances, including dental, they do have TMJ coverage. You can explore that. For oral sleep appliance, it's a medical insurance. If I do orthodontic treatment, that's a dental insurance. I try to make it better for the patient. Like, patient benefits are my first priority. And my functional therapy, I tried to look for the way to work with medical insurance. I didn't find it. So if patient chose to do, that's a patient responsibility. But we try to be flexible and find a way for patient to do that.
And does it work in terms of your treatments? How do you determine if this is working? How often is it working? Is it failing? I mean, what are some of the outcomes you're seeing? You can pick a couple stories, or just generally speaking?
Absolutely. I'm going to start with the general statement, and then I'll give you the story. Regarding the treatment, my traditional oral appliance therapy treatment, always, every single patient have to be returned back to medical doctor to have sleep study done afterwards. So that's how treatment gets checked. And if it's not good enough, it's very embarrassing, and I have to find a way how to make it better. And I use different resources, including myofunctional therapy, nasal hygiene, physical therapy. Like, I have a lot of tools in my toolbox. Regarding when I do treatment in conjunction with myofunctional therapy, I do check that with the sleep study as well. And I have cases. I'm going to tell you, like, this is my story, which was a long-term story. I'm going to tell you the story about Ted. So I met him in pulmonologist office when I was in the beginning of my sleep apnea, dental sleep medicine journey. I visit pulmonologist office to see what happened on the consultation. So I met this beautiful family, a wife and a husband. Wife brought the husband because he was snoring, asking for it. And the pulmonologist gave him a CPAP machine. But we like each other from that moment, and he became my dental patient, like regular for clinics. He didn't live too far. And I watched his whole journey. He was a great patient for CPAP. He was wearing CPAP religiously. He had some atrial fibrillation issues. So then at certain point, he came to me and said, CPAP is great and it's working great for me. And wife doesn't complain and I feel much better, but I'm traveling. Do the oral appliance for me. And I did the oral appliance for him. And oral appliance worked great for him also. We did the sleep study, CPAP worked, oral appliance worked. And actually, this combination of treatment, according to the recent article, Dr. Macer and Fernanda Almeida, they issue that research for the combination of treatment when people can combine CPAP and oral appliance work the best as a compliance as well as blood pressure control. And then all of a sudden, this patient come back to me and said, I'm not wearing oral appliance anymore, and I don't want to wear CPAP anymore. I just don't want it. I can't take it no more. Come up with something else. And that time, he had some crowding. It was not terrible crowding, but it was lingually inclined things. I said to him, okay, why don't we, if you don't want to wear it, why don't we try myofunctional therapy and orthodontics? I'm going to expand your arches dentally as much as I can. And we're going to do myofunctional therapy. It's a low course. It's going to take you 6 to 8 months. And I teach him how to breathe, how to hold the tongue, how to hold the lips together. At the same time, expanding the arches. And it was a huge surprise for his pulmonologist to see the repeated sleep study. He did not have sleep apnea without oral appliance and without sleep apnea. So he didn't have a sleep apnea. Sleep apnea disappear. It cannot be miracle. Miracle have to be rechecked every 5 years. And if he get any symptoms, if he gain weight, I see him as a dental patient and instruct him all the time. But that's the true story. And it really represents what sleep apnea is a journey. It goes through the patient life, and patient priority change, and the treatment have to change, and we have to adapt, and we have to be equipped.
Yeah. And as you're saying that, and thank you for sharing that, it's a lot more work. And the talk I gave recently at Winds of Change in St. Louis, that was one of the underlying themes was, why should I care? Like, what this requires a lot more time and energy on our part. We have to really care about this on a deeper level. If you are a busy general dentist or a busy pediatric dentist or a busy orthodontist, and you are doing more the routine dentistry that we were taught in dental school or in our residencies, it's really hard to be motivated to want to do something to change. But you have to care at a different level, because it's really easy to just keep doing what you're doing. Change is hard to begin with. And then you're going to acknowledge that maybe you haven't been doing it the best way for all these years. And then you've got to retrain your staff and your team and develop these relationships with other colleagues and all of these factors. And I don't say that in a way, again, to intimidate people to not go on this journey. I say it more as a explanation of why I think a lot of people justify and rationalize in their own heads why they don't go on this journey as providers. Because it's sometimes easier to just keep doing what you've always done and what you were taught to do and tell yourself, I'm not causing any harm. I'm restoring this person's teeth. I'm giving them night guards, and I'm helping with I'm straightening their teeth in the orthodontic standpoint, or in a pediatric dentist, the rampant decay, which we know can be from mouth breathing and as well as from diet. I'm just going to keep doing my stainless steel crowns, and I'm not going to ask these airway questions. I just encourage our colleagues to listen to what Maria is saying and start to think about how your practice could look different, how your days could look different. Because in hearing you speak, Maria, you are so passionate about this. You're empathetic with these patients. You want them to be better. You didn't have to go on this journey. You really didn't. You could have kept doing dentistry and been very successful at it. That being said, it wasn't enough for you. You wanted to do more for these people. And I can hear it in your voice, because it reminds me of in my voice when I talk about the kiddos that I help who come in just because they have a crooked tooth or not enough room for their teeth, and I detect their airway. I put them through my screening diagnostic process, take the cone beam, go through the sleep questionnaire, sleep questions with the parents, realize what's going on, figure out if they need to see the ENT and or allergist, and work together to get to the bottom of this. And at the end of this, you have a child who is a different human being. And you have parents who are in tears, and you have a little kiddo hugging you, and you have parents in tears because they're like, you saved us. You saved my child. You saved our family. And it's so rewarding. And I'd like to hear if you feel differently, but I've never met anyone, whether they're doing it more in the adult case that you were just talking about with Ted, or in the pediatric cases I was talking about, generally speaking, who does it and gets one of those experiences and doesn't think, oh my gosh, I have to do more of this. There's something I'm missing, right? Have you ever met anybody who experiences that and is like, yeah, this isn't for me. I don't like the way this feels.
I think if people crack the code how to do that, of course they're going to be that way. It's just, it's just hard to get on that path. And a lot of stars have to align in the same way. But if you have that desire inside, I think anyone can do that. You just have to have that maybe vision, how you want to see yourself. No, you just have to think about yourself, like who I want to be when I grow up.
Yeah. Yeah, I love that. So what would you say to the younger docs out there who have a lot of young docs that listen to this show, even residents and dental students? They're hearing these conversations, and they're starting to think differently, and they are kind of confused. What if they're going to go into a practice where the senior doc doesn't think this way, and they love this practice, and it's in a town they want to be in, or their significant other, spouse wants to live in it, whatever it is, and they say, I can't change the way they do it too quickly. And that's a point of conflict for them. And they might not be able to go start their own show or want to right away. That's not for everybody. Or they go to work. There's so much corporate influence now in all of the dental profession, specialty and general. And the corporates are about the bottom line. And they might not have the systems in place to work with medical billing and the things you were mentioning. Could you just give them some advice on what you would recommend? Well, I'll just steal the one you just said, which is find your vision, because I love that, and who you are and who you want to be. And I would just maybe add to that, it won't all happen at once. Like, you don't expect that in a day you're just going to be here. It's a journey. But how else could you advise them to be able to do some of this with not knowing a ton about it and maybe having some pressure from above telling them they shouldn't?
I totally feel for them. I totally understand. When I finished my residency, I was crazy looking for guru. I really want to find that smart kid dentist who I'm just gonna follow his or her footsteps, and I'm gonna be like that person. But for me, it did not happen. It did not happen. I keep finding people who didn't have big dreams or big ambitions, and I was working in a corporate place, and I was doing pediatric dentistry actually. But as a doctor, even you in a corporate environment, when you know who you are, you educate yourself and you offer it to the patient, and eventually maybe you're not going to do whole sleep apnea journey like I described. Yes, for that you have to have a freedom of your own practice. But you're going to do certain part, and you're going to feel good about that. You start with a certain part. I can say with restoring one tooth and educating the patient. Restoring one tooth and educating the patient. And people talk about time and all of that. Of course, you can find opportunities. You can find obstacles. It's just what you're looking for, half full, half empty. That's your own philosophy. But when you're on that journey of being in a corporate, you create a certain ecosystem around you. You create a certain reputation, how you want to do things.
It's true.
And then, yes, it cannot happen in one day. You come in and there is a trust and patient wanted it. But eventually, even in a corporate ecosystem, you put yourself how you wanted to do these particular procedures and these particular services, and that's how you visualize and you start establishing the network. I think the network, who you going to surround yourself with, one of the things what I didn't understand, and maybe because I was from Russia, how important network is, how important is surround yourself with the people you respect, and people who you want to grow into. And that's why we're having our programs, because I want to learn from people. I want to gain the knowledge. And you find opportunities. Now it's so much easier. We have LinkedIn, we have social media. You find people you want to follow. You attend a lot of educational seminars. And again, symposium, you surround yourself with those people. And yes, it's not going to happen fast. It's going to take a long time. But then eventually you have that net what you can jump out to, either into your own practice or not even. You can practice for someone else, but you just have your firm criteria, how you want to do that. And then you find your pathway, and you're still going to be in the city you want to be. Yes, it's very important, but it's going to be your reputation. And those cases, what you want to treat, they're going to come to you. Or you're going to see them as those cases.
I love the taking little steps in this. And for the orthodontists out there, it can be as easy if you go into a practice, or even a pediatric dentist, if you're in a practice that's more restorative based and you're wanting to incorporate some of these concepts of airway. I love what Maria just said. That is, just start by doing what you're doing already and just then add a little bit. Do that plus 1%. Give a little education. Ask them some sleep questions. Ask them some behavioral questions for the parents of these kids. Just start asking, because even though that corporate or that senior doctor may be opposed to it initially, just remember they're coming at it from the standpoint of they don't want someone new coming in and changing their whole practice, and they're very proud of it. And I've been the senior doctor. I understand what it's like. We're trying to recruit somebody, and it's anxiety provoking in the senior doctor standpoint to just be like, well, I mean, I'm not going to do everything differently all of a sudden. So take baby steps. And then when you do get those wins, expose your senior doctor or whoever it is to it and say, hey, I found this out and this is what it uncovered, and have them meet the patient, and or in the case of a family, the parents and the patient. Let them feel what you got to feel on that just one case. So educate yourself, be willing to step outside the box, take baby steps, develop your network, and then bring the other docs in your practice into that feeling so they can have the emotional pull. Because I really do believe the vast majority of us out there practicing went into this for the right reasons. I really do. And it can get, you can get off course, and some people that does happen to, but ultimately we went into this because we wanted to help people, and we wanted to do work to help others live their best lives. We just didn't maybe learn some of the other ways that we can do that. And that's what you went on that journey to do. I went on that journey to do. And then everybody, that rising tide lifts all ships, right? The more you start to bring them up. So instead of going in and fighting those senior doctors and telling them we need to do this, right? Like, for those who are on the audio version, Maria's shaking her head, like, because it's, that it's going to be futile. It's going to become adversarial. It's going to be, and then they're almost not going to want to do it because it gets to just be hostile. I love that. I love what you just said. Just little by little, start incorporating some of these concepts in your patient care and then go from there. That's really great, because that was a question I just get all the time, and I've never explained it in that way. And so thank you for breaking it down in a way that I know these young docs now, because it can seem intimidating, but it doesn't have to be. The only other part too is, and I know you'll echo this, they have to do their part and do their homework to get educated on this stuff, right? I mean, they have to.
That's very important.
Yeah.
It's very important, but it's rewarding at the same time. You, on those courses, you meet people who have the same interest.
Yes.
And you're learning from them. And it's not a big concept. It's easy to grasp. Not easy to grasp, but small practical steps. That's what you learn from your network. How you do this, how
Yes.
I do this, what do I do with this code, with the medical insurance, how do I work with my medical doctors, how do I create collaborative teams. So yes, there are a lot of levels. And guess what? I'm learning every day.
Yeah.
Every day. That's why our job called practicing. We practice.
Right.
We practice the best way. And this is very new to me, but I thought no one actually born with those knowledge. We gain those knowledge
Right.
as we walk this journey.
Right. It doesn't end when we're out of dental school. And I so agree as well with the people you meet. That has been one of someone like you. I mean, just the people I've encountered on this journey since I went in this direction of putting myself out there and having this show and putting my content out there. It's amazing. You can get locked into some of these social media groups where it's all the negative people and everyone's hostile with one another in their professional environment. I've distanced myself from a lot of that. I created my own doc community on Facebook as well, where it's not like that, and it's not just orthos. It's open to colleagues of all types of the team that we need. And I don't get in the middle of all that as much anymore, because it was a waste of my time and energy. And I realized that those aren't the people I want on my team. Those aren't the people I want on this team. I want people like you, people that have been on my show, people that understand this. And we're not all going to agree, but we all share a vision. And that's the difference, is we all might have different ways we do it, or approaches or techniques, fine. But we all see this differently. And I would encourage younger docs out there especially, break free from that noise. Just don't get caught up in it. You're always going to have the haters. You're always going to have the people on that side of it. Let them be them and do their own thing, and focus on what you can do, which is change the lives of your patients, really.
Thank you very much, Mike. I really appreciate being here. And I have that free gift for your audience, the assessments on myofunctional therapy and sleep. And it would be the video. Doctors who want to learn what myofunctional therapy is, there is a video after the self-assessment. And if people want to join my group, Sleep Apnea Snoring Breathing Help, I would be very honored to listen about their victories and their journey and their challenges. They can find me on Instagram, Dr. Maria Sokolina, or YouTube, or LinkedIn. I would be very honored to connect.
I appreciate that, and making yourself so available for all of that. And thank you for that offer as well. And that is a question I get all the time from people is, what is myofunctional therapy? We talked about that a little bit when I was on your show. What is it, and how does it play into all of this? So that's great. I really appreciate you offering that resource and being available and doing what you do. I so appreciate it and admire what you're able to do for your patients and for the communities, and for coming on the Doc Podcast. So Dr. Maria Sokolina, thank you so much. Really been a pleasure.
Thank you. Thank you very much, Mike.
All right. Bye. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses, or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.